Hello everyone, I welcome you again to this part 2. So in this part 2, we shall look at history taking and examination in dermatology. I'm Dr. Abraham. So when you talk about history taking in dermatology and examination, I usually want you to look at this condition as how can I say, this process as a journey. So in a journey, when you're planning for an adventure, usually you'll see that you have to first figure out which adventure do you want to go. Do you want to go to the mountains? Do you want to go somewhere for fishing? Then you have this enthusiasm that you want to go, that urge, that need that you want to go. But all this is driven by the desire to discover something new, a new scenery, a new map, a new location, and how maybe people live on the other side of the world. So in this history taking, our goal or our aim is to discover actually what is wrong with the patient. So that is our adventure that we are taking on. So as in other fields, when you're taking history from a patient, the very first key important thing is to make the patient that we're talking to very, very comfortable. So in this case, you're doing this to make sure that you create a very good rapport with this patient, a very good harmonious relationship with this patient, such that they can open up and tell you what exactly is the problem. You'll find that someone can maybe have an issue in their genitalia, but if they see that the environment does not support them to start talking about their genitals, they'll actually tell you their nail is paining or something else, and then they'll look and wait for another opportune moment where they will feel comfortable for them to disclose. So usually in this case, I encourage you to use an icebreaker. So here you can crack a joke, you can ask the patient, where have you been? How have you reached here? How is everything? So this initial conversation makes the patient to relax, calm down, and they'll start pouring out their heart to you so that you were able to find actually where the problem is, and they'll be able to tell you the chronology of the disease. Then after you've made sure that this patient is comfortable, you can go ahead to do patient identification. You look out for their number, name, age, sex, and the rest. And here I can encourage you to remember this mnemonic, Nasatorima, and then this is what it stands for. So after that, we want to know the presenting complaint. What exactly brought this patient to the clinic? So you'll find that someone will tell you, I've had this rash for over 10 years, but then why have we decided to come here today? Because if it is 10 years, how have you lived 10 years with the rash? So what is the major reason? So that is the presenting complaint. And then after that, you have to dig deeper into the history of this presenting complaint. And if it is a rash, you have to ask questions like, when did the rash start? Where did it start from? When did you first notice it? And sometimes you can also ask symptoms. Does it itch? Does it burn? Does it pain? So this one is allowing you to know which type of rash and what is actually bringing in the concern. And then you have to evaluate the evolution of this rash. How did it spread? Was it rapid? Was it one rash that developed into others? Or was it just one rash over the entire period of time? Or did the rash come abruptly from nowhere and the entire body was full? So that history should clearly come out when you're taking history in dermatology. And you have to ask things like, what makes the symptoms better or worse? You may find that some rashes are exacerbated maybe by the sun, but when someone takes a cool bath, they feel better. So you have to establish the relationship between the rash or between the presenting complaint and anything else that can make it worse or better. You may find that some rashes are worsened by eating a particular type of food or putting on a particular type of cloth. So that should clearly come out in your history. And then you have to ask what medication or therapies have been tried, be it herbal, be it modern medicine. And if there is any of them, you ask the duration, the dose, the frequency, and was this medicine of any use? What did you see any improvement when using this medicine? Was there any change? Then in dermatology, we are also interested in contact. This issue is very important, and this one usually applies where it is necessary. For example, we want to know, does the person have any animals at home? Did they travel in the last couple of days before the onset of the rash? Did they sleep in any motels? And things like that can give us also a picture in particular diseases or in particular diagnosis. And you have to do still a full past medical history. This one, you assess the chronic illnesses, the medication they are on. And this is a big range, including cancers, any any skin problems, are they HIV positive, any sort of blood transfusion, or any surgeries in the recent past. So all this is supposed to be captured. Then you should create a very special section for the medications used, and then this ranges from all dermatological drugs, be it topical, be it oral, and this one helps us to know what are the other drugs that the patient is taking, how long have they been on these drugs, was there any recent change in their medication, because conditions like drug reactions can only be picked from this history. So this history should come out clearly. Then we want to know the allergies that the patient has. Is the patient reactive to any drug, any food, any environmental triggers? Is it dust? Is it pollen? Is it what? So you need to bring out this history. And then what does the patient love doing? Any habits? Do they love smoking? Do they take alcohol? Do they use any drugs? Do they love swimming? For example, we know that when you go to swim, you can acquire HPV infection. So the history of swimming, if you don't pick it, you can't even know that a patient got maybe this from maybe a public place. Then we go to family history, and then in this case, we're interested to know about all those conditions that are usually genetic. So you can ask things like any family history of conditions like psoriasis, any genetic conditions like the neurofibromatosis, and the rest. So if there's a positive history in the family, then there's also a likelihood of your patient to have a similar presentation. So this one also becomes very key. So you can ask things like, in your family, do you have any issues with the skin? Do you know anyone amongst your relatives, your siblings, your parents with a long-standing or with a chronic skin problem? And then the patient will tell you that maybe my brother has this rash or that or something in that line. Then we're also interested to know about the constitutional symptoms that are associated with the rash, if they are relevant. So in most cases, if you find this section very relevant, you find it being captured in the history of presenting complaint. If there's a fever, headache, chills, joint pains, weakness, weight loss, so all this should be also asked as well. Then you will go ahead to review all the other systems depending on the scenario that the patient is having. So if you think that maybe the condition the patient has is associated with the respiratory system, for example, the child has a scarlet fever, you're thinking about scarlet fever, so you'll go ahead and ask about a cough, a sore throat, and all the systemic symptoms. If you think the condition the patient has a relation with the cardiovascular system, then you ask about questions of difficulty in breathing, pain on exercise, and the rest. You also assess all these other systems, just like in other histories, the internal system, musculoskeletal, and the central nervous system. So after doing this thorough history, we require that you summarize the impressions or the signs and symptoms you have derived from this, including both the strong positives and the strong negatives. I'll give an example here. So if someone presents you and they say they have a rash, it will be paramount for you to tell us if this patient also has a fever. So if the fever is there, then we shall have a line of thought that maybe this is rash, maybe due to an infectious process, because someone already has systemic symptoms. But if you tell us there's a rash but no fever, then you're like, hey, maybe it is something else. It may not be infectious. And then uh, after that, you can write us maybe your impression from the history that you've taken. What do you think this condition is? So you give a list of differentials so that when you go on to examine the patient, you have a line of thought where your thinking is. So after that, we now proceed to patient examination. So in dermatology, when you are doing our patient examination, remember we are looking at the skin, the adnexia, we are looking at the nails, we are looking at the hair, the mucous membranes, including the genitalia. So it is very, very important that one, you ask the patient for consent to allow you to examine them. Then two, you are doing this in a well-lit room. Three, you are going to expose the body. So if the patient is maybe not comfortable, we encourage that you expose them in bits. You can start to expose maybe the upper part of the body. Then after that, when they dress up, you do what? You expose the lower part of the body so that you get to look at each and every part of the patient and then see if you're able to elicit or find any rash or any abnormality on the skin, hair, and the nails and the mucous membranes as well. So when you ask the patient and they are now allowed, we have a few tools that we usually use. We can have a magnifying glass or lens or a dermoscope. You may need a measuring ruler so that you know the length of these lesions, and you need examination gloves. This one is usually for infection prevention. And after that, when the patient has now undressed, you want to inspect and see, where is this rash? How does it look like? What is the texture? Is that okay? And then you see what is the type of this lesion, what is the shape, what is the size, what is the distribution, how is it arranged on the body? Is it linear? Is it clustered? Then after that, then you look at the nails. How are the nails? Is there any nail changes? How is the hair? Is there a change in color? So this one, when you're examining, you first give a broad picture. For example, I'm examining a 16-year-old or maybe a teenager who presented with a rash, maybe for this number of days, for 3 days, and she's in fair general condition. Then generally, I see maybe a generalized rash, meaning that it's on the greater part of the body. And this rash, how are they appearing? How is the size? Are they polymorphic? Is it just one type of rash, or are they monomorphic? Just all the lesions are looking the same. So maybe symmetrical, polymorphic rash, including maybe a papule, pustule, and the rest. So these primary skin lesions and the secondary, we shall look at them in a video, but when you're examining, this is what we follow. So after that, after inspection, then you go ahead and palpate and see what is the temperature around these rashes, maybe what is the texture, how does it feel like? Is it smooth? Is it rough? Is it scarring? And how are the lesions? Are they elevated? And how is the consistency? In case maybe there's a swelling, is it soft? Is it firm? Is it hard? Is it fracturant? How is the mobility? Is this fixed on the underlying structures, or is it mobile? And is there a pain when you touch? Then it is it for tenderness. And then the special examination test that we usually do, the one I mentioned earlier, is a dermoscope. We use a dermoscope to see and magnify the skin a little bit more to see the underlying structures. This is very key when you are making diagnoses like for melanoma, when you're looking at even cones, colors, and warts, you can use a dermoscope to see the difference. And another equipment we usually use, we call it a Wood's lamp. And this is very key because sometimes either infection or some conditions, when you shine light on them, they tend to effervescence, or they give out light, they give off light of a particular color and wavelength. So when you pick that, you can even make a diagnosis from just the Wood's lamp. And then the rest, patch test and biopsy, those ones we just show them in details in the subsequent video. So now after that, you have now picked your examination findings. We want you to make a good documentation of these lesions, depending on the size, the shape, color distribution, and any other relevant characteristics that you may find. Then in dermatology, usually we love taking pictures, because when you take a picture, even when you have forgotten something, you just go back to your picture and see what did I miss? How were the lesions looking like? Then you compare and see what is it most likely to look like. Then before you take off these pictures as well, you have to take consent from the patient and inform them why you're taking off these pictures and what are you going to use them for. So you tell them maybe you are using this for reference to make sure they have a before and after treatment picture so that someone knows you're not taking their picture for your personal benefit. And then after documenting all this, then you give us your working diagnosis or impression, and then this should be recorded clearly. But then after this, you have to give us a list of differentials in case your diagnosis is wrong. What else can it be? So you have to give us all that list, at least maybe 3 to 5 differentials to work with. And then after that, you outline your plan. What are you planning to do for the patient, both starting from medical and non-medical treatment, so including patient education and then also follow-up. How will the follow-up plan be? Are you intending to see this patient after a week, 2, or even a month, depending on the condition that you've diagnosed? So you have to give a diagnosis, differentials, your treatment options, both medical and non-medical, and a follow-up plan. Then, when you are doing patient education and follow-up, you have to explain your findings. So to make sure that the patient understands clearly what you think they have. And this is very key because our skin conditions don't have local names. Like you may find they don't have a Chiganda name, a Chinyankole name. So you need to explain to the patient to the best way possible about their conditions, either they are not misinformed or call it cancer or syphilis or something that is familiar to them. Then you have to also explain the treatment options you are giving or any procedures that you are intending to do. You talk about lifestyle advice, skincare, sun protection, depending on what is necessary or on the prevailing circumstances. Then you schedule follow-up visits to monitor treatment response and any necessary adjustments. So Wood's lamp, this lamp looks like this, and it's very good. This one emits light, blue light, and that blue light, when shown on particular conditions, the color you see can give a diagnosis. I have here a table that tries to show you which color you see in particular conditions. For example, in vitiligo, if a patient has a vitiligo, use a Wood's lamp, you get this chalk white to dull bluish white fluorescent, which comes off the skin. And this is characteristic in vitiligo. And then when someone has ashy leaf spots, this one is usually in those connective tissue conditions, you end up with enhancement of the hypopigmentation. And then for infectious conditions, for example, if you have Pseudomonas aeruginosa, it will shine for you green. If you have Corynebacterium, for example, someone has erythrasma, you'll get this chlorate fluorescence. And then if you have propionobacterium, this one that causes acne, it will shine orange red, usually when you shine it on comedons, especially if they are the white, the closed comedons. And if it is pityriasis vascular, it will be a little bit yellowish, though these colors are very hard to see in people of color. So the easiest one to see is usually vitiligo and then erythrasma and maybe Pseudomonas. These other fluorescence are very hard to see in the people of color. And we know that some fungi like the Trachophyton scaleni will give you a blue-white fluorescence, and then also Microsporum species will give you blue to green or yellow to green fluorescence. So this is very key. You can remember this table. So every time you're using a Wood's lamp, maybe if you're suspecting a condition in one of these in the table, you use a Wood's lamp and it can give a clue of what is going on. Then the next one is a Dermoscope. It looks like this. So you take your microscopic view, you try to magnify the skin to see what is going on. And it has been very useful in diagnosing things like cancer. For example, this is the dermoscopic fissure of a melanoma, and then you can clearly see these edges. You can see that it has very many colors. You can see the irregularities around the edges and all the ABCs of the melanoma. You can actually pick them, some of them on the dermoscope, and this is how it will look like. So I want to thank you very much, and if you've learned something new today, We thank you for watching this video to the end, and I will encourage you to subscribe to this channel so that you keep learning more and more in dermatology. And in case you're interested in us teaching you something new in dermatology, just put it in the comment section and we shall review it and then organize and prepare a video in that section. Thank you very much. I am Dr. Abraham from A&E Dermatology Specialist.